The following Agios-supported podcast is intended for informational and educational purposes only and is not intended as medical advice. Please speak with your healthcare professional before making any treatment decisions. The guests on today's show were paid to participate in this podcast.
Welcome back to Just Listen, Voices of PK Deficiency. I'm your host, Dr. Rachel Grace. I'm excited to introduce our guest for today's podcast, Dr. Andreas Glenthøj, an international expert in pyruvate kinase deficiency. Dr. Glenthøj is a hematologist and researcher at the Copenhagen University Hospital in Denmark at the Danish Red Blood Cell Center. He focuses both on lab-based and clinical research and clinical trials in genetic red blood cell disorders. Dr. Glenthøj has been an investigator in multiple clinical trials for pyruvate kinase deficiency, the PK Deficiency or PEAK registry, and the recently published International PK Deficiency Guidelines. Dr. Glenthøj, welcome to today's podcast.
Thank you very much, Rachel.
I thought we might start by hearing from you a little bit about how you became interested in research in genetic red cell disorders.
Well, it was kind of random or serendipity because most of all, I thought I would do the same as most other hematologists. I would do malignancies. That's the common thing to do in adult hematology. I did my PhD on white blood cells, on neutrophil granulocytes. I got into studying a bit of iron and how iron could mean something for infections. So that was a dream for me to do something that was non-malignant hematology, or what we like to call classical hematology today. But looking for a job afterwards, that was not really easy in a country like Denmark, where these diseases are even more rare because there's few patients. So even though you're specialized in something, you would have very few patients. And then during my fellowship, all of a sudden, the professor who used to do red blood cell in Denmark, he needed to retire. And they were looking for someone who actually did lab work and also was, in their opinion at least, okay with patients. And somehow I fulfilled both of those criteria. So they approached me and say, would you like to do red blood cells? That would be thalassemia, sickle cell. They didn't mention pyruvate kinase deficiency. And to make a long story as short as possible, I said, I know nothing about red blood cells. I'm probably not the right for this. And they said, well, that doesn't matter. Give it 14 days and your phone will be ringing and you'll be the national expert because no one cares about red blood cells. Well, that sounds kind of interesting. Why not give it 2 weeks and see how it goes? And they were right. All of a sudden, I found out the basics of red blood cells, of hemoglobinopathies at least, and I started seeing out patients with red blood cell disorders. And then a year later, I got a patient referred who had a disease I never heard of before, pyruvate kinase deficiency. I thought I'd better read something about it. I found some work done by wonderful researchers, such as yourself, and tried to figure out how to manage patients and found out, well, actually, pretty much we're trying to treat them like thalassemia. That was what I could read back then. And that seemed kind of easy at that point to do something. And all of a sudden, I could also try to find more patients. And I found out I had at least 4 patients. And then you, Rachel, gave a wonderful lecture at EHA in Stockholm. And I thought, well, that sounds interesting. I actually just met a patient with PK deficiency. So I went up to you afterwards. I don't know if you remember, saying, well, I actually have a patient. I might even have 4 patients with this disease. And then a few hours passed and I was still the same day in Stockholm. And all of a sudden I got approached by Agios. I don't remember by mail or phone, saying, do you have 4 patients in Denmark? And they were impressed. And I figured out, well, actually we have many more. Today at my institution, we have 18 patients, I think. And in Denmark combined, we have 32 patients. So it turned out we have a lot. And all of a sudden, I was engaged in clinical research and got the chance also to do some lab work. So that was the very long introduction to how I got into PK deficiency. And it turns out you can actually become a clinical hematologist without knowing too much in advance.
Agios is a biopharmaceutical company that's fueled by connections with patient communities, healthcare professionals, partners, and each other. Building on these connections and the company's unmatched leadership in PK activation, Agios is pioneering therapies for rare blood disorders, including sickle cell disease, thalassemia, and PK deficiency. To learn more, visit us at agios.com. That's agios.com. To join the conversation with other patient allies, follow us on Instagram at Ally Voices Rising.
Such an interesting journey. Have you found, since you became more focused in this area, that there are trainees or people approaching you with interest in this area, that it's growing in terms of what you found over time compared to when you started?
Indeed. And normally, if you don't do anything new with patients, if you don't do any research, it will always be something where people choose it because they didn't get the good chances in hematology. They will choose red blood cells because, well, I didn't get a chance to become a leukemia doctor, then I might as well do something else. With all this interest about novel treatment options, I think makes it much easier to attract good doctors to doing classical hematology. So at least in Denmark, it seems like it is something that people actively choose and not because they weren't chosen for other things. So that's really a pleasure to be a part of that journey.
I think too, as there are more treatments available and more that's known about specific conditions, I think the awareness even of those hematologists who sort of have a broad range of clinical practice have become more aware about conditions like pyruvate kinase deficiency. So I think, in addition to the excitement of new physicians or researchers in these areas, I think just having more information within the research realm or medical realm, I think, has drawn the attention of some hematologists who might see a mix of both malignant conditions and classical hematology conditions.
I fully agree. And all of a sudden, we also get better at diagnosing these things. And it goes hand in hand that you get interested in things, you get new tools. We have whole genome sequencing. I think you probably do a lot of genetics as well when you don't know what it is. And it used to not matter if a patient had one or the other hemolytic anemia that they were born with, because the treatment was pretty much perhaps remove the spleen. You could give blood transfusion and inoculation. But otherwise, there was no real difference in how we saw patients. Now we know that certain complications are very common in PK deficiency, as we'll probably talk more about, but all of a sudden we're interested in the bone structure. Do they get osteopenia, osteoporosis very early? Do they get pulmonary hypertension, liver problems, other things where we all of a sudden gain knowledge about these diseases? I think it's kind of the same you saw with paroxysmal nocturnal hemoglobinuria, PNH, where we used to have no treatment and pretty much patients died. And all of a sudden we got complement inhibition that was able to change the course. So patients were able to live as long as others, pretty much. And then there was a registry where we gained knowledge about it. And all of a sudden we have many different complement inhibitors competing with each other. And all of a sudden prices are dropping. So we're actually able to treat many of the patients and improve their quality of life and length of life. So I hope this is the first steps that we're now experiencing more and more interest in these diseases.
Absolutely. I think as we had the information come out of registry studies in pyruvate kinase deficiency and out of the clinical trials, we've had this real explosion of new information about pyruvate kinase deficiency. And with that, the international guidelines were put together because now there was this body of evidence we could look at in terms of making recommendations around diagnosis and monitoring and treatment. And I wondered if you could talk a little bit about the development of the international PK deficiency guidelines and why you think they're important.
Well, first of all, I was glad to be invited because you and Hanny were central parts of inviting the few people in the world that were dedicated to this disease. And I think it turned out there were 29 people involved. It was quite a few. But the first part, asking the questions, what do we need in guidelines? And then having professional help to dig through the evidence to try to figure out what is actually something we can say because of clinical studies or registry studies, and what can we say if we derive it from other diseases, which would primarily be thalassemia? Even though I really don't like the idea of saying we treat patients with thalassemia like this, hence we should treat patients with iron overload and PK deficiency the same way. I think it's fair to somehow compare the two diseases in terms of some complications. But then we spent a lot of time developing the questions, how to diagnose, how to monitor, how to treat patients. And I think that was a really interesting journey because it turns out we actually did have some high quality evidence. We had phase 3 studies of pyruvate kinase activation, but also being aware of the complications that could occur, how frequent they were. And my favorite example is bone density, because if we look at it in both the natural history study and also in the registry study. It's a common but still rare complication. What I think is striking is when we actually look at the Activate studies where we did bone density scans on patients, we all of a sudden discovered if we look for the complications, we actually find them. It was most of the patients in those studies, and those were young patients who actually had either thin bones, osteopenia, or osteoporosis. That was a surprise to me that was actually something that mattered, especially because luckily these patients grow old at some point. So if you have osteoporosis at age 28, chances are you will get bone complications that matters later in your life. So having focus on these diseases, I think was great. And well, I can talk for hours about this. But when we built these guidelines together, I also think it's important because one thing is when you meet an international expert such as you, Rachel, or others in the group, you might get high quality care and the investigations you need. I think the problem is most patients in the world, they don't go to one of the institutions that have, well, not many patients, no one has that, but someone who actually handles more than one or two patients. So having a piece of paper where you can say, well, this is recommended. I need this either in the States and other countries where you have insurances, saying this is a part of the normal workup and monitoring of my disease that I need, instead of having to, well, do with whatever's randomly chosen for you. So I think that was the main part of it.
You made the excellent point that if you don't actively screen for a problem, particularly one that doesn't have symptoms or doesn't yet have symptoms, you won't know whether you have it. And so that points to the difference between what's reported in a registry where everyone has different screening practices, as you're saying, seeing different providers where certain tests may not be done, versus a clinical trial where everybody has the exact same screening test done and you can see what the real percentage of a problem is.
And it's the same with iron overload. We used to say, well, if you don't get transfusions, you don't need monitoring for iron overload. It turns out I did start monitoring that because I grew aware of it through these studies saying, well, there is actually a problem in patients who might have received one or two transfusions in childhood, and all of a sudden they're 40, 50 years old, and turns out they do have problems. Or patients who got a lot of transfusions in childhood, and no one really cared about that they got a transfusion, many transfusions back then, and have a ferritin of 3,000, and they might have severe iron overload in their liver and risk serious complications. The problem is when they have their cirrhosis, it's probably not reversible anymore. So we really need to be sure that we're doing the right things, that we're monitoring, testing for the right things. And probably there are things we don't know of yet that should be monitored, but we haven't asked the right questions and found out yet.
Let's talk a minute about iron overload and the recommendations around screening in the guidelines. Can you talk a little bit about the types of tests that are recommended and which patient populations?
I think the first part, which is surprisingly difficult sometimes, is merely to get a ferritin. It's not a good test, but at least to screen that. And we know from, at least from thalassemia, if you have a ferritin less than 500, it's very unlikely that you will have severe iron overload on an MRI. But if you have more than 500, well, there is a risk that you have iron overload. And that can be in the liver, that can be long-term dangerous, or in severe cases, might actually be in the heart. And what we know from non-transfusion dependent thalassemia, at least, it turns out that the risk of getting iron overload other places than in the liver is actually more common than you would think if you just look at how much iron you have in your whole body combined. And it is more dangerous to have iron in the liver, in the pancreas, in the brain. That can create problems. So that would be the first step, to do a ferritin. Then if you get a significant amount of transfusions, you would also need to do, at least at some point, do monitoring for iron overload by MRI. That is the precise way to do it. And the current standard many places would be to just look at the liver. And at least in the guidelines we wrote, it would be that if you have too high iron, much iron in your liver, then you should also do an MRI of the heart. And that can be debated where the limit is. I think we put it at 7 milligrams per gram because that is normally what we do in thalassemia. Then we extrapolate what we do in thalassemia. I think it's very much dependent on institutions because some of the MRI machines, it's the same they use for heart and for liver. So if you go to Denmark, we would do both because when the patient is lying in the scanner anyway, it doesn't take much longer to do both. In other institutions, you will go to the radiologist for one scan, you will go to the cardiologist for the other scan, which is logistically at least kind of silly. But I think it's fair to do both. For the future, for research, I think there's other organs we should be testing as well, but the problem is the routine of looking at spleen, of pancreas, other organs, the routine is not very good there, so that would only be available in few institutions.
People listening might feel worried about some of the organs you mentioned in terms of iron overload. That tends to be, as you said, that the MRI measurements, if people are able to get the MRI, could be of the liver or of the heart, but typically not of other organs like the brain or other intra-abdominal organs. Should people feel worried about iron overload in those places?
In general, I think the risk is quite low. And I think these organs can be monitored in other ways, because one thing is if there's a little too much iron in the organ, but monitor for that and by the liver and by the heart, that would be the most important part. And then we should be screening for diabetes, for instance. It's usually when you go to your GP, you would be screened for diabetes by looking at how much sugar, how much glucose is on the hemoglobin. So you look at, on average, how much sugar has red blood cells been exposed to, and normally red blood cells live for 120 days. The problem is in PK deficiency, they only live a fraction of those 120 days, so you can't use the test for anything. So it's very common that patients get screened for diabetes the normal way, and it's missed. So what should be done instead, and that, in my opinion, should be done at the institution following your PK deficiency, would either be just to do a simple glycosis, fasting glycosis, just a random glycosis measurement. So you measure the sugar in blood, and if that's normal, well, that's a decent screening for that there's no overtimes of diabetes. Then you can also look for in more details by giving sugar and measuring how your body reacts to that. What's recommended differs. I don't think there's anything I should say that you need to have it this way, but it should be at least tested. Then you know that your pancreas is still working. And I think that's the main part. And the same way about hormone monitoring. If you have some signs of iron overload in your liver, in your heart, then sometimes, depending on how severe it is, you should have monitoring of some of your hormones to see that that is not affected significantly, both in children, of course, when you're developing, but also in adults.
There may be people listening too who don't have access to getting an MRI for measuring liver iron. What is recommended in those individuals?
Well, you would have to do with what is normal in many places in the world in thalassemia, and that would be hopefully to measure ferritin, which would be available in most countries with a healthcare system where you can treat it anyway. And we used to just use the ferritin as a pseudo measure and think, well, at least in my institution, if it was more than 1,000, then you would start treating it and try to get it less than 1,000. And I'm sure that most patients were actually doing quite well on that. The reason why we like MRIs is to make sure that there's a relationship between the ferritin and how much iron you actually have in your body. And that is not a perfect relationship, and it can also be affected by different types of treatments. But I think in all institutions where they can afford to give targeted treatment, they would also have access to MRIs. Otherwise, measuring the ferritin and giving normal iron chelation treatment, if available.
And can you speak to differences in the guidelines with regard to screening recommendations in those who are transfused versus those who aren't transfused, and around different aged individuals?
I think iron overload is simpler to look at if you get transfused, because most of the iron will go to the liver. So the risk of you getting severe iron overload in the heart and the liver is not filled with iron and you don't have a high ferritin, I think is less pronounced than in non-transfusion dependent patients. So actually, it seems a lot simpler to monitor those patients. So for iron-wise, that would be, well, not simple, but easier. And you're asking about, remind me, other complications as well.
At different ages, so transfused and non-transfused, and then looking at ferritin or MRIs based on age of the patient.
Well, pretty much you wouldn't normally, and again, I'm not a pediatrician, but if you have a child who's 1 or 2 years old, you couldn't really bother by doing MRIs. That would not be, well, you need to do anesthesia and get them in. And it's not worth the effort because it won't have any consequence. But around years 2 or 3 of age, you probably start to monitor. And I think depending on the institution, when you start to do MRIs, when you just do the ferritin, I don't have a precise answer there because I don't have the experience firsthand by patients there. I only have what we discussed in the guidelines. But then if you get transfused, I think it's fair to do an annual MRI to make sure that you don't get iron overload despite what the ferritin might be. if it's less than 500, you shouldn't get iron chelation. So patients would normally be have more than 500 in ferritin. And the reason why I say it should be less than 500, that sounds counterintuitive. If I was a patient looking at my blood sample saying, I have a high ferritin, I would say, well, why don't I do more iron chelation? I want to get rid of the iron. You keep telling me that iron is dangerous. And the reason is that if you overchelate, if you give too much medication to pull out iron of the body, you will start to actually take other things in your body, think other minerals, and draw them out of the body that can cause bone problems, other problems. So it's important you don't overdo it. You keep the patients at the right range. And when you do the MRIs, you don't want to go less than 2 milligrams per gram, then you would be overchelating your patients as well. If you don't get transfusions, I would think it would be fair to do at some point, if you have more than 500 in ferritin, a baseline MRI, and then adjust the frequency depending on the phenotype. So looking at the MRI baseline saying, okay, if the ferritin is 600 and there's no iron overload in the liver, I wouldn't repeat it every year. I think that would be a waste of resources, both economically and for the hospital. That's not my primary reason, but also it's a lot of time and effort for the patients, especially for children, because they both need to come, and I don't think it's much fun to do an MRI. And also for the caretakers who need to take days off work and travel. And in some cases, when you see patients, I remember telling me, well, it's a wonderful institution in Boston, but you have patients who actually fly in to meet you and get the right treatment. I don't think anyone should travel long for an MRI if there's no real good reason for it. If the ferritin is more than 1,000, I think I would probably do MRIs annually on non-transfusion dependent patients. But depends very much on the specific case.
That was very helpful. I think, as you mentioned, ferritin is a tricky measurement, and in children in particular can be a tricky measurement because it increases in the setting of infections in particular. And so it's one that needs to be followed over time, as you're saying, so that if there's one level that happens to be very elevated in the setting of someone being ill with a virus, it's important for it to be remeasured. And that happens in young children all the time, where we have to take it in the context, as you're saying, with everything else going on with the individual. Are they getting transfused? Are they not being transfused? Is there a reason to expect the ferritin to be very elevated?
And that's a very good point, because obviously, and as you mentioned, especially in children, when do you get a blood sample? Well, you get a blood sample when you feel more sick. So that would be when you get an infection. And if you come to my institution, they say, well, this is a patient with PK deficiency or some sort of strange anemia that Andreas is interested in. And they somehow measure ferritin. And then if you have a ferritin of 1,000 and you get an infection, it might all of a sudden be 3 or even 4,000. Patients naturally worry that is my iron status gone from bad to much, much worse. And obviously, it's just a pseudo measure. It's not a real measure of iron overload. And when you get infection, other things, inflammation of some sort, it can go through the roof. And you need to repeat it under calm circumstances. I agree, fully, as usual.
I'm going to go back to something that you mentioned earlier about bone density and the risk of low bone density as a complication of pyruvate kinase deficiency. Why is that something that's seen, and what's recommended in terms of screening and the guidelines?
Well, I think even though I'm lab-based, I wouldn't have the exact explanation. But in any disease where you have a hyperactive bone marrow, that's definitely not healthy for building strong bones. You have expansion of building new red blood cells because you desperately try to keep up with all the red cells that keep breaking for some reason, in this case, for lack of pyruvate kinase activity. I think you need to do what is possible. And in any patient, taking vitamin D and taking supplements of calcium, I don't see any problems in taking normal recommended levels of that. So usually I do recommend it just to be on the safe side. You can also monitor it, and that is what we recommend in the guidelines, to make sure that it's not low levels of vitamin D. On the other hand, living in a country like Denmark, and I'm sure also in Boston, most parts of the year, people will lack vitamin D because there's too little sun. So for that reason, I think it's fair to recommend it for most patients since it's such a common complication. If you do get osteopenia and osteoporosis, well, actually, in young patients, you still can only do vitamin D and calcium supplements because the treatment, which would be zoledronic acid or other similar products that we use to really strengthen the bones in patients who have osteoporosis, the problem about that is that can damage unborn children. So if you become pregnant later on in life, that can be harmful. So it's not recommended that anyone wants to get children. Actually, it can be detected in the blood years after that you actually got it. So I would very, very rarely recommend it to anyone who planned, at least females that plan to have pregnancy later in life. So for that reason, preventing it with vitamin D and calcium as best as you can would be fine. And to build on that, if you have osteoporosis at a young age, it's probably not that dangerous because it just means you have thinner bones than the average of a similar aged person of the same sex. So usually when you're 30 years old, you have strong bones. So even though they're less strong than they usually are, they likely won't break. But the problem is that 20, 30 years later, if you keep on having thin bones compared to others, then that will eventually become a problem. So when you turn 40, 50, when you're done with having children, then you can give the stronger treatment to preserve the bone as best as possible, I think.
I think one important piece to highlight too in terms of the guidelines is the recommendation around screening for bone density issues at a much younger age than is generally recommended in the healthy population. And even just the recognition, as you're saying, that this is an issue in young people who have pyruvate kinase deficiency. And so being proactive about attention to vitamin D and calcium and bone strengthening exercises starting in childhood is really important. So anything that we could do in a preventative way so that maybe will impact that rate of low bone density that we've seen in the Activate trials, as you mentioned, that if we're preventative and proactive in the younger ages, perhaps that can change over time.
And thank you for pointing that out, because doctors have a tendency only to think of tablets and injections. And exactly, you're right, that doing exercise is a very useful measure to prevent it. You shouldn't stop doing exercise because you're afraid you have thin bones. On the opposite, the more you can do, the better. As it is with most diseases, the more active you are, the better. So I think that's important. And also, when to start these, I think in the guidelines, I think that's fair to say when they turn 18 at least, we should do a baseline DEXA on them to know, are these individuals at risk of getting even more osteoporosis later in life? And if it turns out to be fully normal there, I would be more calm and I would adjust the monitoring frequency according to that. How often that is, that depends on institution preference, and there's no evidence-based answers. I tend to do a DEXA at least every 5 years just to get some sort of idea. And if there's any signs of osteoporosis, osteopenia, I would do it much more frequently. But again, thinking of how often should I do this? It's an X-ray. It's not dangerous in any way. It's a bit of radiation, but much less than you would get from taking a flight. So I wouldn't worry at all about them, but I wouldn't do them just for the fun of it if there's no real consequence. I think it's very useful in making patients aware that they do have thin bones, because if you're any age, but especially if you're young, remembering to take something as boring as vitamins and calcium supplements that you perhaps would feel that's something that your grandmother would be taking instead, it can be persuasive to say, well, right now you have thin bones. Think of when you get, as old as me, 43 in my case, you might get problems from this. I think that can be motivating. So that's, I think, one of the main reasons to do it.
I'm going to switch gears again a little bit and ask you about pulmonary hypertension as a rare complication of pyruvate kinase deficiency and what the guidelines recommend in terms of monitoring.
Well, I think that was a very difficult one because it's such a rare complication. It was only a few percent of the patients in the registries that had pulmonary hypertension. I think there are different risk categories we don't know yet, but in general, I would suspect the patients who have what's called intravascular hemolysis, that means the red blood cells, they usually break inside your blood vessels. That can be detected to some extent by how high your lactate dehydrogenase LDH is. So I think there are patients that are probably more likely to have these complications, but we don't know. And I think it would be a pity just to say if this blood sample is normal, there's no risk of anything. I think it's fair to do, as I think we did in the guidelines, to at least have some sort of baseline monitoring when they are adults, to make sure that we screen for that. And I think many pediatricians would opt for also doing it through childhood to have some sort of idea, are these patients at risk? And I have patients who have small signs of pulmonary hypertension, but to be honest, I have yet, with the 18 patients I follow, and to experience having a patient with that complication myself. But I sent them to the cardiologist to get it tested, and I used to do it every year because that was what was recommended in sickle cell disease. But given that I never found anything, and the cardiologist kept asking, do you really think we should invest time every year in this? I made the agreement that they could adapt depending on if they find any signs of pulmonary hypertension. So I think every year is probably too frequent for most. Every 3 years, I think would be good for many. At least every 5 years, I think would be prudent to do to get some sort of idea of it, because that would have therapeutic complications. And most patients with pyruvate kinase deficiency, they have fatigue, dyspnea, symptoms that could relate to pulmonary hypertension, but that could just be attributed to the anemia itself. So looking for things that are hidden from the patients, I think could be very useful.
Yeah, I think it's a problem where it's hard to discern the symptoms being directly related to that specific problem, as you're saying, versus symptoms of anemia. So I think unless you look, you don't really know. And so getting an echocardiogram or other evaluation with a cardiologist is what's recommended by the guidelines. And I think in particular, too, and we don't have to talk about every possible situation, but in thinking about young women who may be considering pregnancy, that might be a time where getting an echocardiogram beforehand to evaluate for a baseline would be very useful.
Definitely. As with both thalassemia, sickle, and also pyruvate kinase deficiency, a pregnancy is, I would call it a risky situation, but still it's something where it should be monitored closely. By someone who actually knows a bit about these diseases, because chances of getting complications is likely higher. You might have different transfusion requirements during pregnancy. Well, likely you have. Several of the patients we discovered in Denmark, we diagnosed in Denmark, they were actually found late in life. You usually in pediatrics, you find your patients very early, probably just after birth, because they have very pronounced symptoms, usually needs exchange transfusions right after birth. Many of the patients I find nowadays in adult hematology is either because they have some anemia and all of a sudden we are able to do whole genome sequencing and find out, well, turns out they have PK deficiency. So anyone, anywhere in Denmark can actually diagnose this, because they just need to say, this is an anemia, can I get it tested? But the other way, which is not that rare, is that patients who might have had a low hemoglobin for all their life, they get transfusion requirements in pregnancy, and it can be quite severe. And that was one of the first patients I diagnosed, was because of, she was diagnosed many years ago, but she was discovered that she had anemia in her first pregnancy and turned out to need transfusions, and actually after pregnancy even. But it took 20 years before we found out we had PK deficiency, because it's difficult to diagnose. But it's a risky situation. Then there's the iron overload issue, because you really need to have good iron status before you commence a pregnancy, ideally. Of course, if you are pregnant, we'll have to find out how to manage it as best as we can. We like not to give iron chelation during pregnancy, but giving deferoxamine or desferol during at least the third trimester is no problem at all, because it doesn't pass the placenta. It's not excreted in milk either, so you can also lactate and breastfeed and still take it. And I think that can be important in patients who are not overly well iron chelated before they get pregnant. But talking at the heart, usually we do an MRI during pregnancy if there's any risk at all of iron overload. We also do an echocardiogram and an echocardiography to make sure that things are as they should be. And of course, if they have too much iron in the heart, it's extremely important to monitor the heart function during pregnancy, because that can be dangerous. But luckily, I think we're good enough to iron chelate most patients. So I think it's a very rare complication.
All of this, I think it's a lot of information for people. And I think we have the intention of wanting the guidelines to be readily available for people, both patients and clinicians, and digestible and usable so that they're implemented into patient care. And something people might be wondering is, how can they use the guidelines for their own care? What would you recommend that they do so that these screening tests that we're talking about get integrated into somebody's individual care with their clinician?
The paper we wrote, it's published in a very nice journal, Lancet Hematology. There are quite good tables, actually, where they point by point have the questions that we asked ourselves and found out we should be doing these things. So there's pretty much a checklist of what should be done. It can be seen, what is the degree of evidence of the recommendation we have? Should we measure ferritin? Yes, we should. Is the evidence very strong? Actually, formally speaking, it's not very good evidence, because we haven't tested how it is to measure ferritin and how it's not. But we agreed, all of us, 100%, that we should measure ferritin. And then you're going to go point by point, say, 92% of physicians interested in PK deficiency think it's important that I get this monitoring or I get this diagnostic test, and then demand that you actually get it if it's available in your healthcare system at all. So I think the tables there are very useful. I also think that the PEAK registry did a nice job of trying to present some of the important information to patients. It's fairly freely accessible, so if you go to the webpage of the PEAK registry, then you're able to, as a patient, to go in and actually look at how common are different complications. I think at least many of the patients I meet, they have a very profound interest in studying their own disease. So the research sources are there. We also had a paper in, I think it was Hematology, where we wrote about some different scenarios, common scenarios about how to manage patients. And there are some very nice, I would call it case stories, where we try to illustrate common things, how we would see them as clinicians. I think that's probably more patient-friendly.
There is a separate website that's pkdguidelines.org that is specific to this guideline to make it readily accessible to patients and clinicians. And members of the patient groups have also had created web pages within that website that make the information even more digestible so that this information is readily accessible both to people who have a scientific background and those who don't, so that you can download a copy of the guidelines, but also see where different areas are highlighted as we are highlighting on this podcast. The different complications and screening, those are highlighted specifically on that website. So we would send everybody listening over to that website to have access to that so that they can download a copy of the guidelines and bring them to their next visit with their hematologist or primary doctor. And what we also hope will happen too with, as Dr. Glenthøj was mentioning, that the level of evidence, why was this recommendation made, is part of the guideline. And we hope that will help with the payers in terms of the decision to allow for a test to be done. And that's different by in the United States, every insurance company that covers individuals, and then in different parts of the world, the different payer systems or governmental policies. And so we hope that having that information about the evidence to support the screening practices and why screening is important, what we hope will happen in terms of improvement in health with leading to screening and early intervention on what's found, that we hope that the data that's in the guideline will help support that practice of screening and what's recommended.
And I think the table you mentioned, where you can see both the evidence and how many recommended it, it also says how strongly we feel about it. And most of the recommendations, we feel very strongly that patients should have access to this. So in some cases, it's not as strong. And then it might be okay to disregard it. But things like monitoring iron overload and also bone density, I think is important. And it's stated very clearly that this is something we really feel that patients should have access to anywhere. And I'm glad to hear that it's available for patients as well. And I also think it's a very good point about the patient advocacy groups, because years ago, that was not really organized to the same extent, but all of a sudden meeting wonderful patients who actually try to put out this on different social media groups, on web pages to make this information available. And I also have some patients who really have great value in communicating with others, meeting patients from all over the world. I've had physicians call me from other countries saying, well, I heard that this treatment you gave to a patient in Denmark, that was a patient getting red blood cell exchange transfusions, that could be beneficial. Could that be something we should test in our patient? And I think at least sharing that knowledge is very useful, that patients internally can gain knowledge and hopefully educate also the physicians treating them. I'm always open to being educated at least.
I wondered if there was anything else that you wanted to add to this conversation about screening and complications in PK deficiency around the guidelines, or any advice that you would give to people listening.
I think one of the things that's usually overlooked is the jaundice, that patients, both children, of course, if you're a teenager trying to look normal at school and you are very yellow in your skin, jaundice, that really matters to patients. It's not dangerous, well, except from just after birth, where it can be problematic, but otherwise not dangerous at all. But patients really feel inhibited by that, in my experience at least. I meet usually older patients. Sometimes they are 40, 50 years old, but they still remember how at least it used to affect them. And when we, in some cases, are able to do something with them, give them treatment to help it, it actually turns out that even though they are 40 or 50 years old, it still matters to them that they don't look as yellow as they used to do. So I think looking at that, asking about that, at least talking about how it affects you, I think is important. Whether it can be treated, how it can be treated depends very much on the situation, but at least acknowledging the problem, I think, is quite fair.
I can't agree with you more. We have lots of conversations in pediatrics around jaundice, and in particular, as you mentioned, in adolescents and young adults. And it really is shocking and disturbing the degree to which, unfortunately, other people are not kind around jaundice, peers who tease other peers around skin coloration. And so I completely agree. This significantly impacts quality of life. I mean, it really makes a big difference in everyday life, even if somebody feels well, if they don't like the way that they look or they feel others are, acting differently towards them because of how they look, it makes a big difference. Dr. Glenthøj, thank you so much for all your helpful insights today. I really enjoyed talking with you and appreciate you joining today's podcast.
Well, thank you very much, Rachel.
Thanks for listening to Just Listen, Voices of Pyruvate Kinase Deficiency. Don't forget to hit that follow button in your favorite podcast app so you don't miss an episode. Share the show with members of the PK Deficiency community. And if you'd like to learn more about PK Deficiency and see what resources there are to support people impacted by PK Deficiency, visit knowpkdeficiency.com. That is knowpkdeficiency.com. Thanks for listening. I'm Dr. Rachel Grace, and we look forward to talking with you again.